Let's take a breath, right? Let's get excited for this last part of the session, and then we're going to go have lunch, and then we're going to go to the other sessions. But I just want to be sure everybody's ready for this, because this is a very exciting final speech, final keynote of the day. Senator Bill Frist, of course, was the Senate Majority Leader in the U.S. Senate for much of the 2000s. He is a noted surgeon. He is the founder and director of the Vanderbilt Multi-Organ Transplant Center. And I have to read this. He has he has authored over 100 peer-reviewed medical articles and chapters, over 400 newspaper articles, and 7 books on topics such as bioterrorism, transplantation, and leadership. 7 books. And I call myself a writer. I have a lot of work to do. He has also been a leader of the Clinton-Bush Haiti Fund since the 2000 earthquake in Haiti. And in fact, later this month, he's going back to Haiti to do surgery. So he's a remarkable man and has been a leader on the subject of healthcare and helping us create good policy on healthcare. And so it is my honor, and I ask you to join me in welcoming Senator and Dr. Bill Frist. Thank you.
Good morning, almost afternoon. You know, it's been a wonderful day and a half, and the remainder of the afternoon look forward to very much. Today, I will not wear my hat as former Majority Leader of the United States Senate. I was honored, and I mean that, especially as I see the potential for partnership of our government, our taxpayer-funded government, with you, whether you're academia or venture or network engineer or software engineer. It's with great pride that I look back upon my 12 years in the United States Senate. But that is not the voice that I'll use, that of the legislator, but rather it'll be the voice of a physician, of somebody who spent 20 years practicing medicine, who will be doing surgery in the future and in other countries. I speak to you about innovation and medical science and the substantial role that you, sitting here today, as your mind is clicking away in the delivery of improved individual patient care. It comes down to that individual patient. I begin with a quick illustration of how innovation can be empowered through science, to be followed shortly by how science in turn can be greatly accelerated by the smart use of data. My story begins in 1981 when I was a young surgical resident at the Massachusetts General Hospital. I was shocked to learn one day that my dreams of joining some of the early pioneers in this emerging, exciting field of heart transplantation, still early on the learning curve, were abruptly and unexpectedly shattered by a public policy decision. It seemed crazy to me. As published in the New England Journal of Medicine in 1981, the MGH trustees joined with the other local leaders in Boston and decided to put an indefinite moratorium on this new procedure early on of heart transplantation. A moratorium, no more, stop, we're not going to do it. They, who I thought, I'd left Nashville, Tennessee, gone to Boston, the seat of innovation, seat of experimentation, the seat of delivery of clinical care, and they said, no, we're not going to do it. It was my 3rd year of residency at that point of time. And the question is why, and from the article itself, the why is really a utilitarian ethical approach, not a bad approach, but we all have to choose our individual ethics as we look at scarce resources, especially in the clinical delivery of healthcare, but also in research. And from that article you can read, it was a utilitarian approach. They did not feel at that point in time it was cost effective. We had to do the most good for the most people, and therefore we're stopping innovation. A young resident, like many of you, sort of looking for the big stuff out there, I left Boston and I traveled to Stanford Medical Center. where at that point in time, and much like many of you are from the West Coast, it was very similar. That was sort of a hotbed of innovation, especially in immunology and transplantation. And there was one man there by the name of Norman Shumway. And Norman Shumway was kind of this iconoclastic sort of guy, did his own thing, but he did it with discipline, he did it with data, he did it with research, he did it at the laboratory, and he took it to the bedside. He did innovate, and my dreams came true. I left Stanford University and went to Vanderbilt. At that time, had never done lung transplants, had never done heart-lung transplants, and we set up a very large multi-organ transplant center that included hearts and lungs and pancreas and liver and bone marrow. It included the gamut of transplantation. At the time, we transplanted hundreds of organs. I had the real privilege of being able to transplant hundreds of hearts, hundreds of lungs. Those patients still I see on a regular basis today, now 20 years ago. We actually cut out a heart, we put it in somebody else, we fly through the night, we pick it up, we put it in somebody else, and that gives them, otherwise they would die, a new lease on life, a new chance to live. And replacing the human heart, moving it around, is still state of the art. But, and this is where innovation and science already progressing, but as you'll hear shortly, if you do your job well, and if government does its job well partnering with you, we can accelerate that innovation. But the sort of advances in science, I'm reminded in this field of transplantation, when I look to an article of how powerful it is, of an article in Nature from 2 months ago, a revolutionary paper in Nature that shows how far the science in heart transplantation has come. For the first time ever, adult stem cells were used to reprogram non-beating cells into beating cardiomyocytes. Non-beating cells all of a sudden will start beating in a mouse model. You see, these cardiac fibroblasts, which are sort of inert cells just sitting there, kind of like scar tissue, can be genetically reprogrammed using what are called retroviral vectors into beating cardiomyocytes. And it doesn't take long, and the picture itself and the slide itself depicts, you occlude the coronary artery, you inject the effector cells itself, it takes these inert fibroblasts, which compose about 50% of the heart. When you occlude the coronary artery, the normal beating heart cells, the cardiomyocytes die, but all of a sudden using adult stem cells, by the way, stem cell technology, you make the fibroblasts, the inert cells, once these die, all of a sudden start beating. It's magic. It seems like magic. It's exciting. It's scientific advance. All of a sudden you begin to think, no longer does Bill Frist need to fly off to Canada, bring a heart back to Vanderbilt, cut out an old one and put a new one in, because you can regenerate heart tissue using adult stem cells. It is magical. You can actually see this in this particular slide. If you look at the top is the fibroblast, the inert cell. It does not beat. Your heart has about 50%, is made up of about 50% of these cells. The clear structure beneath it is a normal beating cardiomyocyte. You'll see it beat in a second. The green structure at the bottom of the screen is also a fibroblast, but it is the one that was injected with those effector cells. And this is what you actually see. Remember, the green are inert cells. The second structure down is a normal cardiomyocyte beating. And all of a sudden, the structure down below is beating, a cell that has never beat before because of adult stem cell technology applied today. That is innovation empowered by science. And that's going to continue. But you're going to be able to take that and instead of working on a slope like this, skyrocketing up by the smart use of data. As most of us who are involved in taking care of patients know, our nation spends millions of dollars on clinical trials that demonstrate how a disease, take, for example, the diseased heart, the heart failure that I talk about, can be treated effectively, clinical trials galore, by a new drug. And it's exciting. And the United States is still the world leader in producing those drugs. Yet despite evidence-based medicine, despite all the clinical trials that we conduct today, some patients get worse despite what the evidence-based medicine, what the clinical trials suggest should happen? Why do some patients get worse despite what is thought to be the right treatment? Is it really the right treatment for you? You have the heart failure, you're getting the medicine. Is it really the right medicine for you, Tom Smith or Tom Nesbitt? Is it the right treatment for you? For decades, that question has eluded us, and it still eludes us today. However, we're continuing to learn, and that's where you come in. As we learn, we ask different questions. We've evolved from asking, how can we improve our research, to asking much, much more robust, much more fundamental, much more probing question. What if what was touted as the right therapy really was not right for the patient? Then I will put on my Senate hat, my majority leader hat. We always hear that 30% of all health care spending in this country is wasted. It doesn't help the patient. When you're talking about trillions of dollars, 30% is a big figure. The Institute of Medicine, and what a tremendous, the awards that we just saw sponsored by the Institute of Medicine. The Institute of Medicine report where 100,000 lives are caused by medical errors. All of a sudden, the right treatment for the right patient says a lot. Questions about the right treatment for the right patient have arisen. At the same time, we're learning a huge amount about human genetic variation. This slide shows some basic ways in which the genetic signal, individual in each of us, may be different in small populations of us. For example, there may be parts of the genetic signal that are replaced as the C is replaced by the T in the first example of a single nucleotide variant. There may be parts of the signal that are removed, or new signals that are added by accident. And there can be a whole host of other, more complicated ways in which the genetic signal may be altered, not all of which are apparent to the naked eye or to the routine test. Many of what used to be considered inconsequential genetic mutations are now becoming critical determinants of how our bodies function every day, how our bodies respond to a particular disease, and how our bodies can best be helped by a particular therapy. And these are the sort of answers that are being sought for but also provided. They form the basis of a very new phenomenon in medical care, one that wasn't around 20 years ago or even 10 years ago, the field of personalized medicine. With personalized medicine, we use the results from extremely sophisticated data analysis to separate a single population of people, say this population in the middle of the slide, that used to be treated with a single drug, into smaller, more discrete, more appropriate personalized clusters of people who share some important physiology or some important biochemical variant that should change how they should be treated. In terms of side effects, will the drug work? Will the drug actually hurt them? Depending on their DNA, depending on their fingerprint, depending on who they are in their genetic code. The slide shows how a drug historically used to treat a large population, that in the middle of the slide, should more appropriately be reserved for a much smaller group of patients. This book, published initially in 1992, has since been updated to summarize much of the new knowledge about the role that genetics play, that the genetic factors play in common diseases of gallstones, of osteoporosis, of osteoarthritis, of skin cancer, of prostate cancer, of migraine headaches. Yes, even obesity and mental retardation and hearing loss, and the list goes on. Another very interesting discussion about this movement, and I encourage you to read it, is a book published this year by University of Southern California professor Dr. David Agus, The End of Illness. A table from his book lists many of the common diseases, all of which have a genetic basis. In the second column is the number of people affected, and on the right side, on the right column, is the cost impact of the disease. And you don't have to calculate going very far to know that the math is significant. If we can only help, if we can help just a fraction, 10% of these, look in terms of that middle column, the number of people who would be infected, individuals whose lives would be lifted up. Look at the far right column, started adding it up a little bit, 10% of those costs taken away at a time where we know that the greatness of America, the future of America, in many ways depends on how we handle the entitlement issue driven almost totally by Medicare, and Medicare being the health care cost we see today. How do we get from a belief that there might be a genetic reason for treatment response differences between two people with the same illness? How do we do it? It's Datapalooza. It's the huge databases that do exist out today, but the integration through you and understanding of the sharing of these databases in a privacy-protected way, using smart approaches, smart apps, smart for the researcher, smart for the consumer, smart for the patient. Vanderbilt University and a host of researchers in the public and private sector are actively combining publicly available data sources. All of my transplants, other than that in California, have been done at Vanderbilt University, and I'm a professor of surgery there now. The ones we're talking about at this meeting, these large databases, let me show you what they can do when de-identified with patient medical records and genomic data to create even more massive databases. These databases link genomic data with medical data with health clinical data. They're being used to discover today the genetic basis behind the predilection some people have for specific diseases, for genomic conditions that lead to rare complications of therapy, even the genetics of medication metabolism that predict which patients will respond to conventional therapy. I've had the pleasure of working with President Bush and President Obama. Initiated by President Bush and propelled forward by President Obama, the first step has been the life work of many of you in the audience who fundamentally believe and instinctively know the necessity of electronically collected data. Our country is now actively at work in converting all of these paper medical records into electronic health record systems, but we are early. As the Secretary said earlier this morning, we're coming along, but it is still very early. But this is the first critical step that puts the data in a form needed, absolutely necessary for aggregation and analytics. This is a very busy picture, which is routine for anybody who practices medicine using electronic health record. It's the home page of the first page, the opening page of electronic health record of a typical patient that would be of mine, a heart transplant patient. This is a heart transplant patient. I've had to block out for privacy reasons, as you can see, any sort of identification. And those of you who are very used to seeing numbers and spreadsheets and clean data probably are a little bit kind of stunned by, good gosh, what is all of this? But this is the reality of the state-of-the-art electronic health record today, where it does combine text and dates and historical data and diseases and medications and genomic data and medical images and x-rays, CAT scans, MRIs, all in a readily accessible database. While useful to the medical practitioner in this form, as you see it, and this has been highly refined in terms of what is most useful for the clinician seeing an individual patient coming through the door, a significant amount of effort, a huge amount of effort, must be put into modifying this clinical format to make discovery possible using these data. At Vanderbilt, we have records for about 2 million patients that have been fully entered into electronic health record and then de-identified for research purposes. 2 million electronic health records that have been purposefully, with all privacy considerations undertaken, with an opt-out consent, have been de-identified for research purposes. We have combined these clinical data with DNA from each patient, with DNA, the genetic fingerprint from each patient that is collected from leftover blood samples. These data are then also de-identified for research purposes. At present, we have over 150,000 electronic health records combined with genetic DNA data, all available for robust discovery and research. This slide shows the detail of that process. When we receive leftover blood from a patient who has not opted out of the process, remember it's an opt-out process, we see if their record has a matching blood sample. If it doesn't, we extract the DNA, we create a hashed version of the patient's ID, and tag both the DNA and the electronic health record with that new hashed ID. We then, once again, scrub the record of all identifiers and slightly modify the dates to make re-identification almost impossible. And this de-identification is ensured by an only one-way flow of information. Let me share a quick example from my own specialty of organ transplantation. Among a group of 150,000 patients upon whom we had genome-wide genotyping data, we identified 1.1 million genome-wide variants and 184 drug metabolism variants. We were able, as you can see over to the right, to study 181 heart transplant patients, many of whom I transplanted back before I went into politics. By combining the genomic data with the clinical data, we've been able to discover or replicate the major discoveries of other institutions. And in science, replication is important to verify what you can really do as you reach out to new discovery. We've been able to do both. Weekly, on a regular basis, we're identifying new associations by coming in and data mining and marrying the clinical data. What happened to you 5 years ago? Why did you get admitted to the emergency room in Tri-Cities when you were on cyclosporin and the local medical doctor started erythromycin? Taking that rich clinical data and marrying it with the fingerprint, the genetics, the DNA data. By combining the genomic data with the clinical data, we've been able to make these discoveries and replications. We've been able to publish preliminary new associations that this combined data just made it possible to discover. It would have been impossible otherwise, such as the 4 listed here. For example, the IMPDH1 associated with acute kidney rejection. And then the combined data sets open up vast new associations of adverse outcomes associated with anti-rejection medicines. I showed you the science earlier. I'm now showing you how we can accelerate that science to new worlds through data mining and the visualization and the application. But we still don't know certain things. We're still using medicines that we don't fully understand what the impact. So to see these associations are powerful, like the new onset diabetes with squamous cell skin cancer, all associated with these anti-rejection medicines. Let me take you just one step further, just a little bit deeper in terms of an example of data-driven discovery and how it translates into clinical practice. We were aware that a large percent of patients on tacrolimus, which is a drug used for organ rejection, develop these dangerous side effects. Dangerous side effects, they cost money, they hurt the patient, all the bad things, add those up, they cause big policy problems that we see in America today. Looking at the data from the clinical arena, the electronic health record, the electronic medical record, we looked at this huge variation that was occurring in blood levels in these patients. We then used the research database to identify a set of patients, which were kidney transplant patients, who happened to be on tacrolimus. And then we used a method, the researchers, the smart guys, the people who are in there just slugging it out every day in the lab, used genome-wide association studies, working with the statisticians, many people like you in the audience. And we identified a very specific genetic variant associated with tacrolimus blood level variation. In the green box, I note that this discovery changed our clinical practice. We changed practice. This data mining, using the data, changed practice in that we now test patients for this variant before starting tacrolimus, and we monitor it much more intensively to look at these blood concentrations for people with this genetic variant. Thus, now we're bringing it down to that individual patient, the person who I actually do a transplant on, that particular patient. We have thereby substantially reduced potential severe side effects, hospitalization, organ rejection, death. The impact on cost and on quality. For the patient, it's important. For America, it's important or self-evident. That's the power. And what you present, what you bring to this room today. Early in the days of NASA, there was widespread recognition that the will to land a man on the moon was going to fundamentally transform a host of scientific disciplines. But we knew it would require, in order to put man on the moon, unbelievable when I was young, it was going to take a whole set of new technologies that we hadn't even thought of. So too has been this journey on personalized medicine. It requires the electronic health record. It requires newer and less expensive methods of assessing genomic variation. It requires the advanced computing that's empowered all of us. It's required very advanced and sophisticated statistical methodology. The move towards personalized medicine requires huge data sets, very large data sets, for both the replication or validation of other people's studies as well as new discovery. And that's where the excitement of taking government and large data sets and integrating them in a way that leads to discovery that we can't even anticipate at this point in time. Many of the events of interest that we're interested in, that I've shared with you today, require thousands of patients over years, thousands and thousands of patient years to identify a single at-risk patient. The power of the data. And to achieve real statistical significance, to take it beyond the association, dozens of such patients may be required. For this reason, the NIH created the eMERGE, E-M-E-R-G-E, the Electronic Medical Records and Genomics network, to begin creating linked data sets of genomic, patient-specific, and general medical information. This requires government partnering with our academic research institutions and our academic and research institutions partnering with themselves. Historically, there's been a barrier in both, government partnering with research and research partnering with research. We got to do better. We will do better. And conferences like this conference, which brings together people from all over the world, in essence, to look at how to use this data, how to share this data in a protected, privacy-protected way, will make that possible. As exciting as the evolution in healthcare is, it only really scratches the surface of what we can do with healthcare data at this scale. Imagine the speed with which we can learn about diseases if there were more national disease registries. Imagine how quickly we could spread an FDA warning about a dangerous medication to all potentially impacted patients. Imagine how efficient an individual case manager might be if she had that timely access, if she had that ready access for an individual from every relevant patient encounter from all potential sites of care. The NIH has been at it. The NIH is one of the advantages I've had of working, doing surgery to this day, doing surgery in the past, being a researcher, and having the honor to serve the United States of America for 12 years in the Senate, where you see the NIH and serving on the committee that authorizes the NIH, they're doing their job. They've been aggressively funding this personalized medicine work. Last night I went on the NIH Reporter, which was funded by our government, and I searched for genome-wide association studies. And that's only one bucket for this kind of personalized medicine genetic funding. And don't try to read the numbers, but the total committed comes to nearly $1.5 billion. That's big. That's a commitment. Those are taxpayer dollars. We've got to keep reminding ourselves these are taxpayer dollars. These dollars are coming from you and your families. They're coming to Washington, and Washington's doing a good job sending them back in order to build for the future, to come back and help that individualized patient who will get the right treatment at the right time, avoiding the adverse effects and all the costs that would otherwise be incurred. I had to pull this slide also last night from the NIH because, again, don't try to read it, but it gives a general breakdown of all the types of projects in the space of personalized medicine, just what I've shared with you, from identifying the candidate genes that cause cancer or heart disease or cardiovascular disease, which is what I do, to learning about DNA signal variants and developing fascinating models of how these variants impact physiology or biochemistry. Each of these projects, each of these little segments that you see there, and again, don't try to read them, each of those segments generate huge sets of data and each will be available for the public, to the public, for research. The power of data. All of this research requires combining and analyzing massive data sets, and it is happening now. We are led to better understanding of disease, how to prevent it in the first place, better understanding of how to treat it once it occurs, with drugs that will target it with maximal effectiveness and minimal adverse reaction for you, for the individual, not the population, for you. That is personalized medicine. And it all comes down to better patient care. It is interesting where I've traveled. I started with basically saying there are times when public policy can stop innovation, and I saw it and it hurt me, and I went to California. I didn't know I was going to go into politics. I didn't know what someday be in Washington, D.C., but it allowed me to fulfill my dream where heart transplantation today is routine. It's routine in Boston, it's routine at Vanderbilt, it's routine around the world. And then I've shared with you the opportunity to take these great advances in science that we see today and magnify them, step function, step them up to a point that we can come back to the individualized patient. I just pulled this picture to close with, and I am going to close now, that it comes down, at least to people like me, it comes down to the individual patient, made possible by studies of population and subsets of populations and imagination and science and analytics. It's really been an honor for me to join you today, and I do, as I've heard all the other speakers do, congratulate you on participating on what truly is a magical journey of discovery and better individual patient care. Thank you. Thank you.
Thank you, Senator. That was wonderful. Wonderful. That was truly inspiring and a little bit scary. I mean, if you looked at that slide that he had of the electronic health record that physicians see, that is almost impenetrable, even for physicians, I'm sure. And as Dr. Frist said, the objective is to turn that data into discovery. That I think is pretty much the mission of the day.